Dana Schwarzbein, welcome to the Vagina Doctor podcast. It's great to have you.
Well, thank you, Duncan. It's great to be here.
You've always got an opinion about things, and I always want to hear it.
Are you sure?
Yeah, but no, I think so. I think so far I haven't been on the bad end of any of those, as far as I know.
That's true.
You went to USC for med school residency and your fellowship
That's
in
right.
endocrinology,
Yeah.
and then you moved to Santa Barbara in 1990
1990
as director of the Department of Endocrinology
at Sansom Clinic.
at Sansom.
Yes,
Sansom was a different beast in those days.
that's right. It was a tertiary center. It
Yeah.
was fee-for-service only.
Mm-hmm.
And so people would come for executive physicals. There's one of
Yeah.
the first places that they did that. So out, the towns outside. But then within 2 years of me being there, they switched to HMO. That's when I left.
Okay.
Yeah. You don't want to hear that story. It's
No, I really
horrendous.
don't. But I do want to hear about your personal interactions with physicians at that time. A, breaking off away and starting your own private practice when everything was going the other way. The condescension that you were met with in terms of when you fail on your own, we'll still be
We'll be
willing
here.
to take you back.
I know, that was funny.
So tell us about that, because a lot
Sure.
of what we talk about here is the difficulty that women have had in progressing in any part, in many, many avenues of life, and what it takes for people to break the ice and to raise the bar.
Yeah. Well, so I was 30 years old when I moved to Santa Barbara, and I was the third female physician that they had hired. It was a multi-specialty group,
Uh-huh.
but I was the only head of a department. So, youngest, female, only head of the department. And you can imagine I got met with a lot of resistance by the older male population, let's say.
Yeah.
But it's one of those funny things. I don't think I really realized it initially when I was there.
Mm-hmm.
And I was, when I came in, I was asked to develop the diabetes program. Sansom was the first place they used insulin in the United States.
Yeah.
I don't know. You
I didn't
would
know
know
that.
that.
Mhm.
Yeah.
Yeah.
And so, but they hadn't had an endocrinology or a diabetes department for years. And so there was like nothing. So I came in with all my big ideas, we're going to make this into a huge diabetes center again. And, let's make, Sansom, let's put it on the map again. And so I started a big diabetes program there.
Yeah.
And I went from 0 patients to being overflowed within 6 months. So it was a really rapid rise. And a lot of it was word of mouth, because what I had started discovering, and for those of you who are not as old as I am, 1990 was really the first time they had home sugar monitoring systems.
Okay.
Yeah, not the continuous monitoring that you now can put on your body, but basically finger sticking. But it was the first time.
Yeah.
Prior to that, you would go to the clinic every 3 or 4 months, get one finger stick, and somebody would decide what insulin you should be on, at that time. Yeah. Yeah, I know. I feel like in our
That's wild.
lifetime, it's so
Yeah.
wild.
Yeah.
It's wild. And anyway, so it was really exciting, because even at USC, where I trained, as an endocrinologist, we didn't get to see those kinds of blood sugars. So this was really exciting for me. We sent people home with their blood sugar monitoring, and I said, okay, you're going to test before and after each meal and at bedtime for 2 weeks. And then you're going to come back to me and we're going to take a look at this. In the meantime, I want you to chart all your food, so I can see what's going on. And at that time, the ADA diet was a very high carb, low fat diet.
Yeah.
Yeah. And again, what I was taught with, and if you don't ever get to see, people's blood sugars, you don't know when they come back,
Right.
why they're not doing well.
Yeah.
So anyway, fast forward on that. So I started to do all that, got some really great results with changing diet in patients, and got recognized by a lot of the internists. So they said, hey, we need an in-service. So I went and gave them an in-service. But at the end of the in-service, the question I was asked, and then looking back, I'm sure I would have answered the same way, because I'm very truthful. But I was asked, oh, did you just learn this? Is this the new standard of care, to go low carb, higher fat and protein with patients? And of course, I'm all excited going, no, isn't this great? I've been learning this here with the patients. We have blood sugar monitoring. I'm changing the diet. We're going to change, how diabetes is treated with this new approach. And one by one, they all pushed their chairs away from the table. And they said, oh my God, we can't do this. And I said, wait a minute. You came to me because you're seeing the success of this program in a very short time with your patients. Getting them off insulin, their needs for blood pressure meds are going down, they're feeling better, they're sleeping better. Couldn't go on and on. It was just amazing. And now you're telling me you can't do this because it's not standard of care?
Wow.
Yeah, so for me, it was like, well, then how does the standard of care change, if you're not willing to look at the facts? But I was supposed to do 3, in-services, and that was it. They all just stopped. And then they stopped referring to me. That was the big one. Yeah, this is my own clinic. Yeah, it was too radical for them. And all I'm doing is manipulating carbohydrate, protein, and fat ratios. I mean, I'm not, using drugs off label or anything. And they just didn't know what to do with that because they were so afraid of being sued. Yeah. That is what they told me. Yeah.
Yeah, and actually California was just about the worst place for lawsuits at that time at the end of the 80s. That's what happened. That's why there was tort reform in the courts here, and how the malpractice cost in Santa Barbara for OBGYN, in my case, was the highest in the country.
Oh, I know that, yeah.
But because of the tort reform, it really hasn't changed much in 50 years. My malpractice now is $25,000 a year.
No kidding.
It's less than it was back then.
Wow. That is surprising because, but I do remember that. But in internal medicine, we didn't have that.
Right.
So that's why I was like, you're going to get sued for making people better?
Yeah.
That was really the approach. Yeah.
It's, a recurring theme of these talks, these conversations, is the difficulty to change the status quo. First of all, people don't want to look at the evidence. And even when they look at the evidence, they choose not to believe it or they ignore it. And so we go from standard of care to evidence-based medicine. And then at that point, nobody's willing to go anywhere else because evidence-based medicine, that was accurate. They did studies. They showed this works, that the evidence there. But it didn't change the practice very quickly. And it certainly didn't change the idea of the population had of hormones, for instance, where it takes so long to change things. So it's really, you've got to actually use your brain a bit in this profession.
I hope more than a bit.
I'm just being generous here. Okay? Just think about this a little bit. It's if you don't push the envelope, it almost loses its impetus because it's so slow to get those changes into practice and to see those things happening, and all the years that you've lost in between.
Right.
Because people wouldn't use their brain to think, okay, this kind of makes sense. And the same thing happens with hormones, which we'll talk about in a while.
And I'll just tell you right here, I know this is going to sound silly, but I never set out to write a book, let alone books, okay? Yeah. But I wrote the Schwarzbein principle because I couldn't, break the barrier. And I thought if it's in print, people tend to believe that more than even a result, So I would have patients where I, as an endocrinologist, my whole field is about biochemistry for me. Okay, so here I'm working with biochemistry. How does the body make cholesterol? It's a known entity. How do we metabolize it? It's a known entity. And yet I would go through all this with patients, and then they would go to their internist who'd say, oh, food has nothing to do with cholesterol, right? And right away, all my hours of education with this patient would just go out the window. So then I finally said, okay, I just can't say this over and over and over again and undo it every time. I'm going to write it down. Yeah. And that made it easier. And so that's why I kept writing. I hate writing, by the way. That's not my thing.
Really? But you've written 3 books.
I've written, Yeah, well, I've had, it's me and a writer, okay, or the last one was me and an editor. And then I wrote a menopause guide, on the way to writing a book. And I have like 4 books in my head right now, but I don't like to write. So it's hard for me, And I do it when it becomes a necessity. It's like, all right, I'm tired of saying that 100 times. I'm going to write it down.
So when you started the diabetic program here, was Lois Jovanovic around?
She
Or
was.
she's there doing research?
She was there doing research, but she had nothing to do with the clinical side
right.
of anything.
Yeah.
And so she wasn't really part of my program. But she was a mentor in a way. Yeah.
Yeah.
The funny story was that it's hard to believe, but the glycemic index of food was known at that time, but it wasn't taught to me in my 9 years of study in becoming an endocrinologist, diabetologist.
Okay.
So when we started doing finger sticks and I started to see, the spikes of sugar with different foods, I started to make a list.
There is a difference, yeah.
Well, I started to make a list.
Another.
Yeah, one carb and another. And because you think 15 grams of carbs, they're all going to do the same thing. So I did this whole list, and I went running over to Lois one day, and I said, look what I've figured out. And she's going, oh, the glycemic index of food. I said, are you kidding me? I've spent months on this, not knowing that it was. But it was at least reproducible. So that's science for you.
Yeah. So private practice. That was hard to do.
Well, I'm very independent. So it was probably the best thing for me. In fact, Dr. Horton, the head of the endocrine department, said, oh, Diana, you're never going to make it in, the private practice sector because you don't like to take orders from anybody. I was a little bit of a maverick, in the department. And so anyway, I think the best thing ever happened is I went into practice for myself. But I'm also, and it's going to sound so incongruous, but I'm a team player. I like to share. I like to work with other people. But I would start to find like, wow, no one wants to work with me. They just, I always feel like they're working against me instead of saying, wow, let's embrace this. She's the endocrinologist. She understands this system that we don't. And yet I would be getting all kinds of people fighting me and saying, well, that's not how it works. I went, what do you mean it's not how it works? Here, I can show you the textbooks, Why are you fighting this off? And I thought it was really because I was the youngest, to be honest. I didn't know it was because I was female.
Yeah.
Because I didn't have that feeling at USC. I didn't feel like it made a difference at USC when I was in training.
I think that too, and I've been reading a lot about this lately, that when a woman especially is really in her power, and same with a man, but it's more accepted, that a lot of people can't take it almost because they feel inadequate, or they just don't, they're going to have like an aversions to being around it. So probably.
It makes them so uncomfortable.
Yeah, it makes them uncomfortable. Yeah, I think it's true. But like with men, it's like, no, it's accepted that a man's in his power and he's doing his thing. But when women are, I don't think it is.
It's frightening.
It is. Yeah. It's frightening. I think people
Watch
are
out.
like scared. Like, uh-oh. Yeah.
Yeah, we're forces of nature to contend with when we get going.
Yeah.
Yeah.
Yeah, that makes sense. And I won't get into all the reasons I left the clinic, but a big reason I left the clinic was when the internists weren't supporting me in what I was doing. And when I left, this is what I had shared with you before, one of the physicians came, we ran into each other at Cottage Hospital, and he said, oh, Diana, really, sad for me, when you come back crawling with your tail between your legs, we'll take you back. I mean, I just love that. I mean, who says that?
Oh God, it's so bad.
Okay, but you know what, Karen? I just started to laugh. I thought, that is ludicrous,
Yeah.
And I said, oh, Jim, you have no idea who I am and what I can do. I will never be back. And I just walked away. But it was so funny because I had considered him a friend.
Yeah.
So that was kind of startling to me. We didn't really talk after that.
Yeah, when somebody shows you who they really are, you believe them.
Yeah, it's very strange.
Okay, so
Fast forward.
Well, it's not that far forward in terms of time, but and it's certainly you ruffled feathers in this direction as well, which is in hormone replacement therapy. So tell me that story.
Okay.
And I want to
Please.
know how you two met or when in this whole process.
Wow, early though, right?
Yeah.
Yeah.
Like when she was at Sansom?
Not
not that early. I was only there for 2 years.
Okay.
So 90 to 92. And then I went out in my own private practice.
It was in the 90s.
Yeah.
For sure.
Yeah.
We began to share some patients at that point because you were doing a lot of work with hormone replacement therapy.
Right.
And I had the patients. And
Yeah.
And for those cases that needed further evaluation.
That's right. We need like biopsies and
Yeah,
ultrasounds and all
right,
that stuff. Yeah.
right.
Yeah. Because I started coming up with my rules of if we're going to do this, let's make it safe. So here's what we need to do, you know, and that included yearly uterine ultrasounds.
Yeah.
Yeah.
Right.
So, well, this also, it actually goes back to the diabetes clinic. So when I first started changing the diet of all these patients that were coming in, 2/3, let's say, of the group was really responding, and then 1/3 wasn't. Okay. And I don't know about you, but I get my best ideas in the shower when water's draining on my head. So I'm in the shower one morning, I go, oh my God, they're all menopausal women who are not responding to the changes. So it's one of those V8 moments where you sit there and you think, how could I be looking at every other hormone system but menopause?
Yeah.
You know, and I think part of that was because endocrinologists are not trained in menopause, if you can believe that. We get, well, back in 1988 to 1990, when I did my fellowship, we had 2 sentences. The first was, if a woman has a uterus, give her Premarin and Provera together.
Yes.
And if she doesn't, well, I guess it's a clause. And if she doesn't, give her Premarin only. That was it. That was what we were taught. And I even raised my hand and said, is that all we're going to get? Because when I'm studying about thyroid, it's so intricate, and we're talking about receptor sites, and we're talking about how T4 and T3 are different in the liver, and they're different in the skin, and they're different in the pituitary gland, you know, and all these little nuances about thyroid hormone. And then you're telling me all we have to do in menopause to balance out the system is give them, which I thought at the time were hormones, right? Yeah.
Right.
But has that changed in what students are taught, or do you guys know?
Well, I personally don't know, but I don't think it's much different.
Yeah, because I don't know if it is.
It's a bit different.
Okay.
In that
It's a paragraph now?
Yeah. No, it's not as much as a paragraph. It's another sentence, which is basically, let's not use Premarin and Provera. Let's use a bioidentical.
Okay, but I'm going to also add to that. In the lowest dosages for
For
the
the
shortest amount of time.
Okay.
Don't forget that.
That still exists.
I know.
That still
I know.
exists.
Yeah, that to me is
You're
a
right
crime.
about that one.
Yeah.
Yeah.
Yeah, that's a crime. Anyway, so when I realized it was my patients who were in menopause who weren't responding, at that time, all we had was Premarin and Provera,
right.
and I was trying to manipulate those drugs, getting nowhere. Okay. Now, back then, this is how old I am, PDRs, right? Physician desk references. We didn't even have the internet where we could look things up. Get this huge book, have to open it up. And so I went to look at the half-life of Premarin because studying hormones have very short half-lives. Okay. And I just, I thought at least if I'm going to prescribe this drug, I need to know a little bit more about it. And I read the PDR and it said the half-life is weeks, and I went, what? This is not a hormone. There's no hormone in the body that has a half-life of weeks. We're talking about hours,
Yeah.
I know. And so that was a big awakening for me going, oh my goodness, no wonder we're in trouble.
Well, what is Premarin? Like, what is it made
pregnant,
out? Is it
pregnant mare's urine. It's
Okay.
It's
Oh.
the estrogens from a pregnant mare, and they're equine hormones. They're not even estradiol.
It's not used anymore, right? Or is it?
Unfortunately, it is.
It is still vaginally.
Okay.
Orally, I haven't seen it very often. Maybe you have more.
No. That's sometimes the first you'll get from some Medicare HMO.
Wow. Yeah, I haven't seen it in a while, but we're talking about 34 years ago. I mean, This is hard to take sometimes, you know. But I didn't really have it, you know, again, I wasn't taught about here are the different hormones and things. So basically, and this is kind of strange, and I don't know if this happens to you, Duncan, but I had 3 people talk to me about Women's International Pharmacy, which was a compounding pharmacy, in the same week. So I had a patient who said, have you heard of them? I had a flyer that came to me in the mail. And then I had a psychiatrist in town, interestingly enough, who was saying, hey, you know, what do you think about these hormones? You know, and it to me, it was like, oh my goodness, that's a sign, you know? So I called them up and I'm like, who are you and what do you do? And when they started saying, well, we make the same, you know, we can make the same hormones that the human body produces. And I'm saying, are you kidding me? Why isn't everybody using this? You know, so that's how I started using bioidentical hormones. And my mom, 34 years ago, was patient X, number 1.
Wow.
She's 91 years old. She's been on hormones with me ever since.
Wow.
Yeah.
That's great.
Yeah.
And
so she went on them.
And she was my patient too.
Yeah.
Oh, really?
Yeah. For hysterectomy. Yeah. Well, we won't talk about her non-compliance, but yes.
She was tough. Well, you know, the apple never falls far.
Oh,
okay.
That's probably true. I think I got that from her and the brains from my dad. But what I did start off with is the same 2 sentences. Okay, if a woman has a uterus, we're going to give her daily bioidentical estradiol and daily bioidentical progesterone.
Right.
And we're going to only give bioidentical estrogen if she's had a hysterectomy. And that didn't budge the sugars either. I'm sorry, did I? No, estradiol.
Okay.
No, just with the hysterectomy, just estradiol.
Oh, yes. Okay.
Yeah.
Okay.
And so, but that didn't budge. Well, that's not true. In the women who just took estradiol, I started to see a change in blood sugars.
Yes.
Okay. But not in my estradiol progesterone daily group.
Right.
So right away, I started to look at progesterone and say, what's going on with progesterone that it's making blood sugars go higher? Because that's what I was seeing in these patients. Instead of getting better, they were actually getting worse, even though it was bioidentical. You know. So anyway, that's where I started to go, oh gosh, Dinah, start using the same rules that you use for hormone therapy for insulin and for thyroid and for cortisol. And these are the rules. Okay, rule number 1, don't give somebody a hormone they can still make, right? Now, I know that sounds kind of ridiculous, but I see it every day. People are getting testosterone who don't need testosterone, and that's actually harming them, okay, because they're getting too much, okay?
Right.
And women were getting started on estradiol before their periods stopped. That's not okay either. Estrogen's in the body at 10 to the minus 12, okay? The moment we start to give milligrams, okay, we're in trouble. Because we're giving them, you know, 6 times more than what they need. And now the liver has to metabolize that. And we have no idea what's going on with all of the different chemicals that it's being broken down into. So that was a big one for me. Okay. And then part of that was also, you have to make sure the woman's safe to take hormones. Okay.
Right.
I didn't do that initially because I thought the gynecologists were doing that. I had to take over at that point. You know, especially when, and I won't name names, but a couple of gynecologists missed a patient who had an endometrial cancer before I started them on therapy. And then all of a sudden, within a few months, they had irregular bleeding and we did biopsies and they had cancers and I was blamed. And I'm like, no, you can't get a cancer in a couple of months of taking hormones. Right. And then to find out that it was already there prior, but it had been missed. But anyway, so then I said, okay, I'm now going to take over and do that part too. So that's why I get baseline ultrasounds on everybody. Okay. So it was safety and making sure that they qualify, and hormone levels were part of that. Okay. The second rule is give the same hormone that's missing.
Yeah.
Okay. So at that time, you might have remembered Jonathan Wright and his whole thing about estriol and estrone and estradiol. And I was going, well, estriol is a urine metabolite. It's found in the urine mostly. Very little is found in the blood. In fact, you can't even measure it, really. And so it's like, why are you asking women who've lost estradiol to slather on estriol? So that's what they were doing.
Yeah.
So anyway, that was my second rule. Like, no, give the hormone that the ovaries make, and they make estradiol.
Right.
And they also make progesterone. So that was easy because everybody knew progesterone. Okay. And then the third rule, this was the rule that had to change in order to help my patients' blood sugars improve. But again, it's one of those V8 moments. Of course, I'm going to mimic normal physiology. This is what we do with insulin injections. This is what we do when we give T4 and T3 for thyroid. This is what we do when we give cortisol. We follow the circadian rhythm of cortisol in the body. So I had to go back and study the menstrual cycle. And go, let's see where estradiol and progesterone are and what are the levels in the different parts of the cycle and, all that kind of stuff. So that's how I got into the cycling of the whole thing. And then the last
all you were doing initially with that was just using the progesterone half the time. Or was it?
Well, no, at the beginning I was using it all the time because that was what I was taught. And then when I started cycling, I went to halftime. Yeah. And the reason I did that without changing the dosages, because I know a lot of people talk about rhythmic cycling, is because I didn't have to change the dosages because the body cells change the receptors for the hormones. And so if you give the same dose, but the receptor numbers change, you get a different effect without making a change in the dose.
Yeah.
So that's kind of where I was going with it, okay, let's make it as simple as we possibly can because I'm barely getting people to remember to start their progesterone and stop it on time.
Right.
Let me add another dimension, and then I started to be able to track to realize, I don't have to add that second dimension.
Right.
Okay. I can get what I'm looking for. And again, what am I looking for? That the patient feels good, that they're sleeping through the night, that their symptoms are all gone, that their cholesterol numbers are getting better, that we're not making their blood pressure worse. If anything, we're making it better. Every parameter. So I'm looking at the whole body and saying, I'm not just looking for what's your period doing or your bleed because there's no more period, but I'm looking to see that what I'm doing is actually improving your physiology at the same time. Okay. So I think that the added advantage of being an endocrinologist is that's my field to look for that. So I'm not just giving a hormone and looking for the effect of that one system, because endocrinology is the study of all the hormone systems and how they interact. So I would be looking at, what's going on with your cortisol if I give you progesterone? What's going on with your adrenaline? What's going on with your insulin? What's going on with your thyroid? So looking at it from a 360-degree view. So I think that's what makes it different.
Are you still doing that cycle dose?
Yes, except for the nice thing is back then we didn't have a patch that stuck on the body. Do you remember the old patches that would always fall off? That was so frustrating because I was like, I want transdermal. But, and unfortunately, at least when I was doing it, the creams, they were just, if you would rub them on, we'd get higher levels initially and then throughout the day, and then they would fade off. And I didn't like the peaks. Again, as a hormone specialist, I'm trying to avoid hormone peaks. So that's why I didn't like the topical creams, even though I like that they bypass the liver.
Yeah.
So then we went from oral estrogens to sublingual to patches.
Like troches.
Yeah.
Yeah, to troches. Yeah. And now we're at the patches, and then it was oral progesterone to topical progesterone, which was a disaster, to intravaginal progesterone, which women don't like to do, but it's the safest because you can give the lowest dosages and it doesn't mess up the metabolism as much as oral progesterone does.
And what compounding, are you still using the same compounding pharmacy?
Well, but my patients come from all over the United States. So
so you use different ones.
Yeah, I use different ones. But the Sansom Clinic, when I first was here, was so willing to work with me that I worked with them until they stopped compounding progesterone.
Yeah.
Yeah, which was just a few years ago now.
Yeah, a couple.
We use Harbor Compounding. Have you ever used them? They're in Costa Mesa.
I don't know that.
They came to fame on the shirt tails of Susie Wiley. They were willing to work with her to produce in a syringe bioidentical hormones in a syringe so they could easily be changed day by day.
Right.
I thought Susie's idea was a great one. I thought it was brilliant to try to mimic that, but it was too complicated to mimic.
Well, the problem with that, because actually Susie was a patient of mine. That's how it all started. You probably don't know that.
I didn't know.
No, I didn't know that. No.
Yes. And she, in fact, she and I were trying to write my first book initially, but she just would take over and write things. I go,
Oh, gosh.
that's not real. You can't write that,
gosh.
you know.
Right.
And I hate to say this, but she did the same thing here because, I mean, we're talking about 10 to the minus 12th, and she's, you know, giving 8 milligrams of estradiol when my patients are on either 0.5 to maybe 0.15 milligrams,
Yeah.
you know. And she, again, it's the same idea. If you just ask somebody, do you feel good on high doses of progesterone? Yes, it converts to cortisol. Cortisol helps you make adrenaline. Guess what? That's the feel-good hormones of the body. So you would slather all this stuff on, feel really, really good, but you would start to get into trouble metabolically. And I was starting to see the adrenals shut down in these patients, you know. And I had to detoxify so many of those patients coming through my clinic at one point. I just started at one point thinking, I'll just start a detox clinic. You know, and if you've ever had anybody had Cushing's syndrome, which is a pituitary tumor where you overproduce cortisol, after their surgery, you know, because they were so high for so long and then they just go back to normal, they're miserable.
Yeah.
It's the same thing. So I had to take people who were on, I don't even know at the highest dose, like I might be making this up, but 1,600 milligrams of progesterone at a peak. I had to bring them down. It took me almost 2 years to detoxify them until I could get them on 5 milligrams twice a day for 14 days of each cycle. You know, it was just crazy.
But I don't know, because if you're cycling and you bring up the Wiley protocol, isn't that the same thing? Because she's cycling.
No, you have to talk about dosages.
Okay.
Okay, so the answer is the same thing because we're cycling? Yes. So you're not taking progesterone all month long, but that's where it ends. Okay.
Because you're taking a different amount of.
Yeah, and it's not even a different amount. If I'm saying to you that you probably need about 0.05 milligrams to 0.075 milligrams of estradiol a day, and you're rubbing 2 to 16 milligrams over a cycle,
Okay.
that's a lot of estrogen. That's not even physiologic. So we're back to what is physiologic and what isn't. Okay. Now, what the body then has to do, the body is designed as soon as you get high levels of hormones to start metabolizing them. But now you've revved up your whole system.
Yeah.
Okay. And you're having to it's like having a toxin. Too much of a good thing is still harmful to you. So the hormones, the estradiol and the progesterone, were bioidentical. The cycling I liked. It was the dosages that were way off.
Okay.
Yeah. Does that make
Yeah.
sense? Yeah. And again, I'm seeing it because I'm starting to see sugar problems coming from these patients. You know, normal sugar to high sugar, normal blood pressure to high blood pressure. Patients came to me complaining, saying, hey, when I would tell this to whoever was giving this to them, and they would actually refer them to talk to T.S. Wiley, you know, she would say, oh, that's not from this program. You have other problems. So they were just being poo-pooed, you know, the symptoms or the side effects were just being disregarded and stuff. So, I mean, I guess you could say one of the good things you can say is maybe she brought attention more bioidentical hormones and the fact that that's important.
Yeah.
But you have to be very careful. Hormones are meant to be given in very, very small quantities. And even then, I know at the smallest levels that I'm giving, it's still more than I would like to give. It's still more than I like to, because we're talking about 10 to the minus 12 versus 10 to the minus 3. Okay, so that is a big difference. So that as soon as I'm giving 10 to the minus 3, the system has to rev up to get rid of the extra, to give me that little bit that I need, because we don't have a way of giving it back. We don't have a way of really mimicking the ovaries.
So in terms of measuring blood levels of estradiol and testosterone and progesterone, are they not accurate?
Not 100%, no.
Okay.
No. So what you have to do there is, I have, since I've been doing this now for 30 years, I chose the last 4 days of the cycle because I wanted to see the biggest effect that progesterone had on estradiol. So progesterone increases the metabolism of estradiol, and it does it by speeding up an enzyme.
Okay.
Okay. And so I just decided I needed a standard for me to look at something. Because if I looked at these hormones at any time of the cycle, they're all going to be different numbers.
Right.
Okay, so right away I said, okay, it's going to always be the last 4 days of those 14 days of progesterone. Okay, and I look at many things. I look at the estradiol level. I look at the progesterone level, which is, it's kind of, progesterone's the hardest one because progesterone's very lipolytic, which means it gets into the cells very quickly through cholesterol, the membranes. So that's the one we really don't want to see very high levels of.
Right.
Okay. I don't want to see it in the normal range because if I do, then I know that I'm overshooting it.
Yeah.
Okay. And then I look at FSH levels. Okay. So those three. And then with the FSH targets, I'm not trying to get them back to normal.
No.
Yeah. So that was it. And then, of course, because I'm looking at every other hormone system, if my patients have I look at insulin, I look at thyroid, I look at cortisol. Those are the big three that I look at. Okay. And then I look at cholesterol levels because those change, and fasting blood sugar levels because those change. And then we look at the uterine lining once a year to make sure it's not getting too thick on what we're giving.
Right.
Okay. And of course, how's the patient feeling? But on the other hand, too, when somebody comes to me, they're not coming to me for pure menopause. I don't have that type of patient. So I'm working with somebody who has metabolic disorders.
Okay.
Okay. So I'm looking at everything at the same time. So it's not the same thing.
Describe that patient with metabolic disorders. Who's
Wow.
that patient?
Okay. So that's
Good question.
that is a good question, but they come in all different types. So I'll try to give you a couple of them. So if you think about metabolism the way that I do, I cut it into two parts. That part of the metabolism that's all about rebuilding the system and making things and producing things in your body. And then that part of the system that's all about breaking them back down again so you can use them and function. So to simplify it, I call it building versus using. Okay. And there are building hormones and there are using hormones. And for instance, insulin is a primary building hormone. So a metabolic disorder in insulin would be that, insulin's not building well.
Okay.
Okay. That's insulin resistance.
Okay.
Way to think of it that way. And then on the other side, the primary using hormones, or the big ones, which I would call major, are adrenaline and cortisol. And so
is cortisol though hard to get a result, like a real result, given the day?
Well,
or
what
how
I
do you do that?
We do saliva collections for that.
Oh, okay.
So you do a 4-point saliva collection throughout the day so you can get the circadian rhythm of cortisol.
Yeah, because that's what I think we do, the blood tests, and I always think that's not going to.
No, a one-time blood test doesn't tell you anything.
Yeah.
So we start with the morning, and then there's a noon one, and there's a 3 to 4 one, and then there's a nighttime one, and we have a curve. And then we don't just look at cortisol. You look at 17-hydroxyprogesterone, which is the precursor to cortisol. And then you also look at DHEA sulfate to see, because cortisol and DHEA are in the same pathways in the adrenals.
Okay.
And you want to see if cortisol is stealing away from DHEA. So you can kind of say, okay, what stage of stress am I in, depending on what I'm seeing with those two levels. So yeah, it's a little bit more complicated than you just get a blood level.
Okay. Yeah. No, I don't think the blood level is the right way to go.
You're correct.
Of course. I never have. I'm like, how does that even, because given the day, it could be different.
Yeah.
Right.
And that's the other thing too. So when I do test for that, I'm having my patients, what did you eat? How did you exercise that day? Because if you're under stress, and just think of running as a stress, okay? If you go running and your cortisol's high, I'm not going to go, oh no, you have high cortisol. I'm going to say, oh, that's appropriate. You went running. Yeah. You're supposed to have high cortisol at that moment. So again, it's one of the hormones that you have to sit there and say, what have you been doing?
Yeah.
What should it look like? You can't just go, oh, it's high and freak out.
Or it's normal, you're fine.
That's right. That's right. So on the using side, it's adrenaline and cortisol, but adrenaline's harder to measure, of course. And so we use cortisol as the surrogate for that, which, by the way, I do want to make a plug for cortisol. It is a life-giving hormone. Everybody's afraid of it, just like they are with estrogen. Yeah. It's a life-giving hormone. It helps convert noradrenaline to adrenaline in the body, and it's absolutely needed to keep you alive. And so A lot of times people will get measured and their cortisol is very high, and then they think, oh, that's a terrible thing. And it might be, but it's not because you have to lower cortisol. You have to improve adrenaline because the body is under stress because you don't have enough adrenaline. And so it's trying to make more. But people are reading it incorrectly.
So what do you do for that?
Karen, you're asking me very...
I'm sorry.
No, it's not that. It's that you're asking me questions that don't have one answer.
Okay.
I want to answer it,
Yeah.
but I'm going to say a lot of things. It depends on what's happening. So if I'm going to look at somebody and say, why is their adrenaline too low? Is it going to be because of their diet? Is it going to be because they're not sleeping well? Is it going to be because they've
Many
overexercised
factors.
or they could just had
Lifestyle,
surgery, infection, all that kind of stuff? So I'm looking for the cause, and then we start working around that. COVID is a huge one for dumping adrenaline now. So long COVID, component of that is a low adrenaline system. That's where the fatigue comes in.
Yeah, and I saw that you're working on that, and so that's a real thing. Long COVID, people.
Very much so.
Yeah. And
it's
fatigue
really
is debilitating.
It's debilitating, and you get the brain fog along with that because noradrenaline is the precursor to adrenaline, and adrenaline, you need that for the mitochondria to make ATP energy. So adrenaline is going to come first, right? So the pathway is dopamine, becomes noradrenaline, becomes adrenaline. And if I have low adrenaline, I'm going to pull from dopamine and noradrenaline. I don't care what my brain is doing. I have to keep myself alive. So I'm going to take my brain chemistry and turn it into body chemistry.
So this is another example of someone that would come to you with metabolic syndrome, or is that?
That's right.
Okay.
Or not metabolic syndrome because that's more on the insulin side.
Okay.
But metabolic disorder.
Yeah. So long COVID falls into that category.
It does.
And we have a lot of patients call saying, I had long COVID. It's one of their things that happened to them.
Yeah.
And I'm just coming out of it.
It can take a year. It can take a little bit more than that too. Yeah. And that's the lucky ones that it can take a year. Because if you already start with low adrenaline and then you dump it even further, you can't get out of that on your own. You actually have to take meds for that. That's what I'm working on. Like, how can we get people out of this, vicious cycle here?
And what sort of meds?
Well, now we're getting into genetics. And why I say that is it all depends on how somebody metabolizes through different enzyme systems. So to simplify it, COMT enzyme metabolizes adrenaline and noradrenaline and partly dopamine, but it's MAO that mainly is responsible for serotonin and dopamine, and there is overlap, but that's kind of how we separate it to make it easy. So I'm looking at the genetics of patients. Do you have intermediate, slow, or fast COMT? For women, do you have intermediate, slow, or fast MAO? Men can only have fast or slow because it's X-linked. They only have one gene that determines if you're fast or slow, and it comes from your mother. So I already know right away when I have a patient who has slow slow MAO, that their son or her sons all have slow MAO. They can't have anything else.
Right.
So that helps them to. Anyway, there's a personality that goes along with that too. It's kind of fun. It's kind of like biochemical astrology.
I don't know why we all don't have an endocrinologist. I just don't get it. I think of all these doctors, but this is the most important doctor right here.
That's true.
I don't know. This is goes right to the nitty gritty.
We're part of the problem.
Yeah, we're definitely. I'm always searching at the cellular level, like what's going on at the cellular level.
And you see people that don't. You see a lot of people remotely, right?
I do. Before COVID, everybody had to fly in once a year.
Okay.
But now we can do more telemedicine.
Yeah.
And stuff. So
well, I want my niece to see you. So. Do you take new patients?
You're not going to ask me that on the air, are you?
Well, we can cut this out.
Okay.
Or we can talk about it after.
Yeah, let's talk about it.
We'll talk about it after.
So I know. So it gets very involved because here's what I will tell you. The endocrinology as what is taught is not really what I do as much. So it's not going to be go to every endocrinologist and get what I'm telling you. Okay.
Yeah.
Because we are still taught with, use all these drugs for diabetes and,
Right.
and do this and do that. And I don't do that. And so, basically it's saying, okay, diabetes and thyroid and pituitary and sex, for male hormones, for that kind of stuff. But I'm just going, I'm interested in this field. Okay, good. I can study it because that organ is hormone related, right?
Yeah.
So I can say, hey, I want to be a cardiologist, and I can study the heart and decide that that's going to be a focus of interest for me. So I do that with cholesterol, for instance. So and by the way, I'm totally against statin drugs. I'm just going to throw it out there.
Okay, so let's hear why. So totally against, totally for. Go. Let's see you two go at it.
I wouldn't have as educated an opinion as Diana, but I would say that this is one of the arenas that I feel the medical profession is well served by, which is the cardiology division of there aren't enough endocrinologists, absolutely. There are probably enough cardiologists. There are so many of them. But I feel like their use of statins is being reasonably cautious, but now really solidly backed up, in my opinion, with data.
So let me tell you from a endocrine standpoint, because I get to see the fallout of all that. Okay. If you look to where statins work, they block sugar becoming cholesterol. That's what they do, glucose at the level of the liver.
Okay.
That's a terrible place to block something because I need cholesterol to make hormones.
Yes.
Okay. So statins really mess up the hormone systems of the body. They really do. And again, I can give you more concrete on that. But more importantly, if I have somebody on the fence who's like a pre-diabetic and I've been working with them like on an insulin-resistant basis and trying to keep them from becoming a diabetic, they get put on a statin, they're going to become a diabetic. Yeah. And, when I was training, basically, and I still think today is known this, the number one patient population that gets heart disease is people with diabetes. And having higher hemoglobin A1Cs is the number one risk factor for a heart attack. So to take a drug that raises my hemoglobin A1C and increases my risk of a heart attack makes no sense to me. Now, you can say those different populations. Where do I think statins are okay? After a first event. And if you're that year, to help prevent, it's a secondary prevention.
Right.
I believe in that for that year, okay, or even 18 months at that point. But not primary, because all I'm seeing is metabolic disorders that are starting to occur from taking statins. And again, it depends on the dose too, if you wanted to use smaller doses. But now I'm even more concerned because they're trying to just drive LDLs to zero, and I'm thinking that is the cholesterol carrier that's bringing my beautiful cholesterol to my cells, not only to make membranes, for cholesterol, but to help me make hormones. DHEA, progesterone, pregnenolone, estradiol, testosterone, vitamin D, and if I didn't say cortisol, they're all cholesterol-based hormones. And I'm watching them, again, if you're not measuring them, please measure. If you're going to give somebody a statin, measure the hormones that they can affect. I never see that happening.
No, that's probably true.
Yeah. So that's why if you don't see it, you don't know it, so you're just going, it's okay,
Right. But I think we've accepted that there is an increase in
diabetes
of
glucose.
Of diabetes or just blood glucose on statins.
But that doesn't work for me.
Yeah.
Well, no.
I don't mean to be contentious, but I will be.
No, of course you are.
We expect you to be.
So there's a real.
But let me ask you this: what do you think you're treating with that? Because it isn't cholesterol that creates coronary artery disease. It's inflammation that does. And it's clotting that does. And lowering cholesterol does not take care of inflammation and clotting and oxidation and all the stuff that actually creates the plaque. So for me, yeah, and you could say, sure, because statins have an anti-inflammatory property to them. And to me, that's the only reason they might work. Okay. Do something else that's anti-inflammatory that doesn't mess up another system. I don't mind. You know, you can, again, look to say, like, what's the cause of this? But if my drug is going to give me a side effect, you know, and it helps me in one way. See, I'm very much for, yes, I want to fix this, but I don't want to fix this and make this worse over here. Okay.
Yeah.
And I think statins maybe fix a little bit of something and make something else worse. And that doesn't work for me. So it's the wrong drug.
Okay. So,
but I'm against most drugs. So don't take it personally.
As we know, relative to Ozempic, but if you plug Ozempic into that equation you're talking about, where you're getting that hemoglobin A1C diminished, and if that's the reason for the atherosclerotic disease, why isn't Ozempic helpful? Because there are good studies now that show that even without the weight gain benefits, there is significant cardiothoracic,
I know what you mean.
Atherosclerotic benefits.
So let's put it this way. So, first of all, I'm against Ozempic and those meds for weight loss. Okay, you're talking about something different here. But but hold that
partially.
thought. Yeah, I'm just saying.
Okay.
But I'm still against them. Okay, so I'm just letting you know that absolutely against them for just like people who saying I want to lose weight, you know.
Right.
Because you're not fixing the cause of their weight problem by giving them a drug. And so you're not really fixing metabolism. And if you don't really fix metabolism, you're not really healing somebody. So this goes back to my building and using system that I'm always looking at.
Yeah.
You know, what are the hormones that help you build? What are the hormones that help you use? You want to match them, okay? Ozempic is going to break you down because it lowers your appetite. That's not a good way to metabolize sugar. You're not helping the cells. I'm looking for ways to get to get the cells to do glycolysis, to then get pyruvate into the mitochondria, okay, to go through that cycle in oxidative phosphorylation to make your ATP. I'm not looking to block those systems. And that, if you don't bring the nutrients to the cells, you're not going through that process. You're going through a different process. So I'm wanting to restore how the body's supposed to be making and using things. So for me, it's insulin delivers the nutrients and adrenaline helps to break them down. And so I'm looking to do things that balance insulin and adrenaline off of each other.
But one of the ways that Ozempic is working is by diminishing appetite and therefore diminishing the amount of nutrients that get into the body that are more than that patient needs.
See, that's where you and I disagree. Most people who are overweight are not overeating. They're not. Their metabolism has been shut down from years of dieting. I used to interview all these patients, and they would start by saying, oh, I was just a few pounds when I was 13 years old, so I went on a diet. The moment you go on a diet, you start to destroy your metabolism, you know, and then they would gain the weight back a little bit more. Then they go on a little bit more drastic diet. And talk about yo-yo dieting. They destroy their metabolism. So at the end, they can't eat anything. Seriously, they're not eating, and they're gaining weight because they have destroyed their metabolism. This is what I talk about metabolic disorders.
You don't think that the excessive carbohydrates that we have in our diet, or the general population, or the standard American diet, is the cause of a lot of this, of the diabetes?
There's two causes. There's overeating. There absolutely. Okay. And then there's undereating. Absolutely. Okay. And if the overeating is that, yes, you're eating way too many carbs, you're turning them into fats, the fats are getting into the cells, they're clogging up the system, and you can have, then insulin can't deliver energy to the cells because there's no room. That's one side. The other side is the under eating, the low carb diet, the high protein diet, the excessive exercise, the intermittent fasting. That shuts down the adrenaline system. So now you have insulin that delivers nutrients, but there's no adrenaline to break down the glucose. So it's both sides. And the problem is that everybody's swinging from one side to the other.
Oh, that's the problem.
The
for sure.
two extremes.
Yeah, they're going from the two extremes. And the moment you damage your metabolism, and this is what we were talking about the other day, when you start to go back to the middle, you start to gain weight.
Yeah.
And nobody wants that, or everybody thinks that's wrong.
Mm-hmm.
So let's say that I was eating, again, it's going to flip back and forth. Eating too much, not eating enough. Eating too much, not eating enough. Then you destroy your metabolism. And now you're just freaked out going, no matter what I do, I'm breathing and I'm gaining weight. And I know that there's a lot of listeners out there who have experienced this because I've been doing this for 34 years.
Everyone.
Yeah. They're all coming to me all the time saying this, and by the way, I believe you because I've been seeing this, and so if you don't know that you can't go back and do something that's right and get a result right away because you have to heal the damage.
Understand.
Yeah. And that's where, again, it's harder for people to understand because
healing the damage. I know there's going to be many answers to this question too, but I have to ask it because I think our listeners are like, well, what do we do to heal the damage?
Well, first of all, there's a lot again to there. So it all depends on where you are in the damage phase because there's different phases of damage. There's early damage, there's middle damage, and then there's really late damage. Okay. So we could use insulin resistance as an example. Early on, when somebody starts to become a diabetic, because they're not born with type 2 diabetes, okay, right. They develop it. And again, there's many reasons for insulin resistance as well, like spikes of insulin and all that stuff. But let's just say that they have a genetic reason for it. Okay. And by the way, a lot of people have genetic issues with GLP release in their gut. Okay. And I don't have them memorized, which I should, but there are things like turmeric helps in that regard. There are things that you can naturally take to help GLP secretion. Okay. So I'm more into that than using
what's GLP?
Meds. Oh, so sorry. Glucagon-like peptide. So when you talk about Ozempic and you talk about Wegovy and you talk about Mounjaro, they are GLP agonists.
Okay, got it. Okay, that's right. I've heard it before. Yeah.
So now I forgot where I was going.
Sorry,
with that's okay.
Just when you take those, you were saying.
Oh, well, what I was saying is if you take somebody, so we're going to watch them get worse.
Okay, yeah.
So you take somebody who, let's say, the first sign that I can find in the blood test is an elevated fasting blood insulin level, not sugar. Sugar stays normal. Cholesterol stays normal. First thing I can find is a fasting insulin above 5.
Now, first thing you can find in what condition?
Starting insulin resistance.
Okay.
But by the way, it can be either because they have too many carbs or because they don't have too many carbs.
Okay, but that's above 5, but that's still within normal range.
That's right.
Right?
That's right, but it's not normal. Up to 25 is normal.
Okay, that's what I thought.
Yeah, but it's not normal. So, and that's the other thing. What we call normal isn't normal. So because I'm looking for, kind of when you're saying, we're going to look before a problem occurs, this is the earliest you can pick up. But if you don't look for it, you're never going to pick it up.
Yeah.
Or even if you're looking for it and you're not interpreting it correctly because it's what they're arbitrarily calling a normal
That's right.
Calling a normal level.
That's right. That's a good point.
Yeah.
Yeah. So we have, so insulin will be the first thing to go up, but it's going up in order to put sugar and fats into your cells. So that's why you can't pick up a high sugar or a high cholesterol level at the end of a 10 to 12 hour fast, because insulin is shoving that all into your cells. Okay.
Yeah.
Then the next thing that starts to happen is we start to see triglycerides going up a little bit. Okay. And that's in somebody going towards the insulin-resistant diabetes route. Or on the other side, what we're going to start to see is LDL particles going up And that's mostly somebody who's more on the low adrenaline side of the equation. We'll start to see that, because if you look at the pathway, it's sugar to triglycerides and cholesterol to VLDLs to LDLs and getting cholesterol into the cell. And then cholesterol has to be metabolized, and adrenaline plays a role in there. So right away, if adrenaline is the problem, then I'm going to see LDLs starting to go up first.
Yeah.
So you can see it that way. So anyway, it's just, you have to kind of look at all of these different parameters. It's not an easy question.
No. So many different things.
I know. I hope I'm not confusing people.
Well, I think we discussed Karen's niece earlier today, and I brought up she's recently been diagnosed with PCOS. And at the advice on a couple of endocrinologists, because we were trying to see what the basis for this was, what was the causative effect and or reason. So we did a 4-hour glucose tolerance test on her after carb loading, and we checked insulin the same time as we took the blood sugar.
Yeah.
Fasting 1 hour, 2 hours, 3 hours, 4 hours. And the blood sugar didn't go up at all. And the endocrinologist I was speaking to said that I don't get this. I don't understand it. But what you're saying is actually...
This is an adrenaline problem.
It's an adrenaline problem.
Mm-hmm.
Yeah.
Very much so. So on that side, it could be, again, either being very active in sports or not eat, or skipping breakfast a lot, or being under some kind of stress, or even COVID. COVID could have started the whole thing.
Mm-hmm.
COVID dumps adrenaline, like big time dumps adrenaline. And that's because glucose to pyruvate requires adrenaline.
Mm-hmm.
And COVID steals pyruvate away from the mitochondria. And so you can't get pyruvate into the mitochondria. So you can only get 2 units of ATP per glucose molecule when you have COVID, versus getting 36 units of ATP per glucose molecule when you don't have COVID. And so you have to use up a lot of adrenaline to make up for the less amount of ATP that you can generate per cell. And that's what dumps your adrenaline in COVID.
Wow. Yeah. Well, she did have COVID, but...
Oh, that would just make it worse.
Yeah.
I mean, I'm not saying that was the cause.
Yeah.
Because she could have had it before, and then it could have made it worse.
Yeah.
Now, when I had PCOS as a teenager, it was because I was a sugaraholic. Now, very different than carbaholic. Sugars actually deplete adrenaline faster than they raise insulin.
Mm-hmm.
Okay, so there's no diabetes in my family. I ended up with PCOS because I burned out my adrenals.
Yeah.
Eating I would mainline white sugar, pretty much. I didn't eat cake. I ate frosting. I didn't eat ice cream. I ate sherbet. I would put a bowl of sugar in milk and drink it.
Oh my God.
All sounds good to me.
Yes. And so when I ended up with an insulin-resistant condition, everybody's like going, oh, like, how did that happen? Then they were saying it was all genetic, and nobody said it was diet related. But anyway, long story short, there's 2 ways that you can have insulin resistance, and that's what's confusing to people.
Yeah.
I think this has to be continued.
Yeah, this has to be continued. It does.
You're a star turn. Will you come back?
I'm sorry?
You're a star turn. Would you come back?
I will come back because I like fighting with you. I'm kidding.
I know. You guys need to fight some more. Yeah. Let's just do an Ozempic episode.
Okay.
Okay?
Yep.
You versus you.
You'll be the referee.
I'll chime in here and there.
Yeah. Well, I hope that I made sense, some of it.
You make lots of sense, and it's been a pleasure having you on today. And there's so much more to talk about.
I know.
There really is.
Well, thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcast, Spotify, or wherever you're listening. Thank you. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. The Vagina Doctor Podcast. It all starts here.